Most people were never actually taught sexual health. They were taught fragments. Use a condom, get tested, do not have too many partners, watch for symptoms. Maybe somebody mentioned HIV, chlamydia, gonorrhea, or syphilis, but almost nobody explained how the whole system fits together. What can be transmitted at which body site, why one negative test can be meaningful, while another negative test is almost useless because it was taken too early, why a urine sample can miss an infection in the throat, why a person with HIV who is durably undetectable does not sexually transmit HIV, why PEP is an emergency intervention with a clock attached to it, why PrEP has changed from one daily pill into several prevention options, or why getting treated for an infection is not always the end of the story if a partner was never treated. That is what this lecture is going to do. The goal is not to make sex sound dangerous. The goal is to make sexual health intelligible. Once the system is intelligible, a lot of the fear disappears because you stop treating every exposure as a mystery and start asking the right questions. What happened? Where did exposure occur? When did it happen? What can be prevented right now? What needs to be tested? And when will that test actually mean something? There are a few situations where timing matters so much that they come before everything else. If you think you may have had a substantial exposure to HIV within the last 72 hours through vaginal or anal sex, shared injection equipment, a blood exposure, or a condom failure in a situation where HIV transmission is plausible, do not wait for symptoms and do not spend 2 days trying to calculate a perfect probability. PEP, which means post-exposure prophylaxis, should be started as soon as possible when it is indicated, ideally within 24 hours and no later than 72 hours after exposure. The standard course is 28 days. A clinician can decide whether your exposure qualifies, but the clock keeps moving while you are deciding whether to call. The same principle applies to severe pelvic pain with fever, sudden severe testicular pain, major rectal pain with bleeding or fever, new vision or neurologic symptoms, in the setting of possible syphilis, or severe one-sided abdominal pain, fainting, shoulder pain, or heavy bleeding when pregnancy is possible. Those are not situations to sit on while finishing an online assessment. They need in-person medical evaluation. With that established, we can talk about sexual health the way it actually works. A sexual health screen is not a morality test, and it is not a single laboratory panel that magically covers every possible infection. It is a structured attempt to answer several different questions. What infections could plausibly have been transmitted? What body sites were exposed? How long ago did the exposure occur? Is there a prevention tool that still matters now? Is pregnancy possible? Is there a symptom that changes the urgency? Has the person been vaccinated against infections that can be prevented by vaccination? And if an infection is found, what needs to happen next so that treatment is completed and reinfection does not simply happen again? The first concept that changes how people understand sexually transmitted infections is that symptoms are a poor screening system. Many sexually transmitted infections are silent. Chlamydia can be present without burning, discharge, or pain. Gonorrhea in the throat or rectum can be present without obvious symptoms. Syphilis can move into a latent phase where there are no visible signs at all. Hepatitis C is frequently asymptomatic for years. HIV can cause a flu-like acute illness, but many people either have no recognizable acute symptoms or mistake them for something else. A person can feel completely normal and still have an infection that testing would detect. The second concept is that the body has separate exposure sites. A urine test does not automatically tell you what is happening in the throat. A throat swab does not tell you what is happening in the rectum. A vaginal swab does not automatically cover a rectal exposure. This sounds obvious once somebody says it, but it is one of the most common reasons a person can say, truthfully, I got tested, while an infection at an exposed site was never actually tested. Modern screening for chlamydia and gonorrhea often uses a nucleic acid amplification test, commonly abbreviated NAAT. The specimen might be urine, a vaginal swab, a throat swab, or a rectal swab, depending on the anatomy and exposure. Ask yourself, during the period you are assessing, was there oral sex, vaginal or frontal sex, anal sex, or contact with shared injection equipment? Do not answer with a label for your identity. Answer with the actual exposure sites. If there was oral sex, throat testing may matter for gonorrhea, depending on the exposure. If there was receptive anal sex, rectal testing may matter for gonorrhea and chlamydia. If there was vaginal exposure, vaginal or urine testing may be appropriate. The point is simple. Testing should follow anatomy and exposure, not assumptions about identity. The next question is when the most recent exposure occurred and when the last complete sexual health screen occurred before that exposure. These are not the same date. A negative test can only speak to infections that had become detectable by the kind of test that was used. If someone tested 2 days after a new exposure, a negative result does not function like a time machine. It does not prove that the new exposure caused no infection. The relevant testing window depends on the organism and the test. HIV illustrates this well. In people who have not recently taken antiretroviral medicines, such as PrEP or PP, A laboratory antigen and antibody test using blood from a vein can usually detect HIV about 18 to 45 days after exposure. A nucleic acid test, which looks for the virus itself, can usually detect infection roughly 10 to 33 days after exposure. Antibody-only tests, including many rapid and home tests, can take longer, often about 23 to 90 days. A fingerstick antigen and antibody test may also have a longer window than a laboratory test from a vein. If antiretroviral medicine has recently been used, detection can become more complicated because the medication can suppress viral replication and delay some test signals. This is why "I tested negative" is incomplete information. The clinically useful sentence is, "I had this type of test, this many days after the exposure, and I had or had not been taking antiretroviral medication." The test is not bad because it has a window period. Every test has a biology behind it. The mistake is pretending that the date does not matter. Ask yourself, did your last negative HIV test occur before the exposure you are worried about, during an early window period after it, or after the relevant window period? If it occurred before the exposure, it tells you nothing about that exposure. If it occurred very early afterward, it may be useful as a baseline, but may need to be repeated. If it occurred after the appropriate window period and there were no later exposures, it is much more informative. If you are taking PEP or long-acting PrEP, follow the specific testing schedule your clinician gives you rather than relying on a generic home test timeline. HIV is transmitted through specific body fluids when enough virus reaches a susceptible tissue or the bloodstream. The fluids that matter include blood, semen and preseminal fluid, rectal fluids, vaginal fluids, and breast milk. HIV is not spread through ordinary social contact. It is not transmitted by hugging, sharing a toilet, sharing food, closed-mouth kissing, touching intact skin, sweat, or a mosquito bite. The virus is fragile outside the conditions it needs for transmission. Sexual risk is also not determined by one fact alone. Receptive anal sex, in the absence of prevention, carries more HIV transmission potential than many other sexual acts because rectal tissue is biologically susceptible to microscopic injury and viral entry. Vaginal sex can transmit HIV in either direction. Oral sex is much lower risk for HIV than anal or vaginal sex, although other infections such as gonorrhea, syphilis, herpes, and human papillomavirus can be transmitted through oral contact. Condom use, the presence of another sexually transmitted infection, whether PrEP is being taken effectively, and most importantly, whether a partner with HIV has a sustained, undetectable viral load can radically change the real-world situation. One of the most important modern facts about HIV is summarized as U equals U, undetectable equals untransmittable. A person living with HIV who takes effective treatment and maintains viral suppression below the threshold used for this prevention. Message: does not sexually transmit HIV. This is not motivational language. It is the conclusion of large studies in which there were no linked sexual transmissions from people who maintained viral suppression. HIV medicine protects the health of the person taking it and, when viral suppression is maintained, prevents sexual transmission. That changes the meaning of a question such as, does your partner have HIV? The more clinically useful follow-up is, if your partner has HIV, are they in care, taking treatment, and maintaining an undetectable viral load? A partner with HIV who is durably undetectable is not the same transmission scenario as a partner with untreated HIV or an unknown viral load. Any risk assessment that simply marks HIV-positive partner as high risk without asking about viral suppression is using an outdated model of the disease. There are 3 broad categories of HIV tests. It's worth understanding. Antibody tests look for the immune response your body develops to HIV. Antigen and antibody tests look for antibodies, and also the P24 antigen, a viral protein that can appear earlier. Nucleic acid tests look for viral genetic material and can identify infection earlier than most standard screening tests. The common laboratory screening approach in the United States begins with an antigen and antibody test, and then uses confirmatory testing when the first result is reactive. A preliminary positive result is not usually the end of the laboratory process. If a screening test is reactive, confirmatory testing is performed. A home test or community rapid test that is reactive needs follow-up in a healthcare setting. This is one reason not to treat a single screening result as a complete diagnostic story in either direction. There is another subtle point that matters after PP. Current CDC guidance recommends follow-up that is more deliberate than simply taking a random home test. For people who take non-occupational PP, follow-up generally includes laboratory testing around 4 to 6 weeks after the exposure, and again at 12 weeks after the exposure. The updated guidance uses a laboratory antigen and antibody test together with a diagnostic nucleic acid test at follow-up, because antiretroviral medicines can, in some situations, suppress the virus enough to delay ordinary test signals. This is one of the reasons PEP should be managed as a clinical process, rather than as 28 pills followed by guesswork. Think about this. Have you taken PrEP PEP, or another antiretroviral medicine during the period you are trying to evaluate? If yes, the practical implication is that standard internet window period charts may not be enough. Tell the clinician or testing site exactly what medication you took and when. If no, ordinary HIV window period guidance is easier to interpret, but the timing and type of test still matter. PrEP means pre-exposure prophylaxis. It is medication used by people without HIV to reduce the chance of acquiring HIV before exposure occurs. The important conceptual shift is that PrEP is not only for people who fit a stereotype. It is a prevention option for people whose sexual or injection-related circumstances create a meaningful possibility of HIV exposure and who want another layer of control over that risk. The United States now has multiple PrEP options. Daily oral tenofovir disoproxil fumarate with emtricitabine, available generically and historically known by the brand name Truvada, is a long-established option and is used across multiple exposure types. Daily tenofovir alafenamide with emtricitabine, historically known by the brand name Descovy, is another oral option, but it is not approved for people whose HIV risk is through receptive vaginal sex. Long-acting injectable cabotegravir is administered by a healthcare provider on a schedule that, after the starting sequence, is generally every 2 months. In 2025, the prevention landscape changed again when injectable lenacapavir was added as an HIV PrEP option. It is given subcutaneously every 6 months after the starting regimen and was strongly recommended by the CDC as an additional prevention option for people who would benefit from PrEP and meet the prescribing criteria. The hidden practical issue is adherence. A medication can be extremely effective biologically and still fail as a real-world strategy if the schedule does not fit the person. Some people prefer a daily pill because it is private and predictable. Others struggle with daily medication but can reliably attend injection visits. A person who travels constantly may think differently about a 2-month injection than a 6-month injection. A person with kidney disease may need a different discussion than someone without it. The best PrEP option is not only the drug with the most impressive trial result, it is the clinically appropriate option that a person can actually continue. PrEP prevents HIV. It does not prevent chlamydia, gonorrhea, syphilis, hepatitis C, herpes, human papillomavirus, or pregnancy. A person can be perfectly adherent to PrEP and still need regular bacterial STI screening based on their exposures. This is not evidence that PrEP failed. It is evidence that different prevention tools prevent different outcomes. Think about this. Have you had repeated situations in the last 6 to 12 months where you later wondered whether you needed PEP, repeatedly worried about a partner's HIV status, had a bacterial STI, had multiple or new partners, or had sex in circumstances where condoms were not consistently used? If yes, the next move is to consider a PrEP conversation before the next exposure, rather than repeatedly managing anxiety after the fact. PEP is post-exposure prophylaxis. It is not a morning-after pill for HIV in the casual sense, because it requires clinical assessment, a full medication course, baseline testing, and follow-up. But the time logic is similar. It is designed for the period immediately after a possible exposure, before infection becomes established. Current CDC guidance treats a potential HIV exposure that may qualify for PEP as a medical urgency. The preferred timing is as soon as possible, ideally within 24 hours and no later than 72 hours. The usual course lasts 28 days. A baseline HIV test is obtained, but if PEP is indicated, treatment should not be delayed while waiting for a laboratory result. Clinicians also consider kidney and liver function, hepatitis B status, pregnancy when relevant, medication interactions, and whether other sexually transmitted infections should be tested for or treated. There is an important psychological point here. People often spend the first 48 hours trying to calculate the exact probability that a partner had HIV, whether a condom slipped enough to count, or whether the exposure was really risky. Some risk assessment is necessary, but the 72-hour clock does not pause while someone tries to achieve certainty. If the exposure plausibly qualifies, a clinician can make the decision. The cost of seeking an evaluation and being told PEP is not indicated is different from the cost of waiting until the effective initiation window has closed. If exposures are recurring, PEP should become a bridge into a PrEP discussion. Current guidance explicitly encourages an immediate transition from PEP to PrEP when ongoing exposure is anticipated and PrEP is appropriate, with the correct HIV testing schedule maintained. In other words, the system should not repeatedly reset to emergency mode if the pattern can be managed prospectively. Chlamydia is caused by the bacterium Chlamydia trachomatis. It is one of the most common bacterial sexually transmitted infections, and one of the reasons routine screening matters is that infection can be completely asymptomatic. When symptoms occur, they may include abnormal discharge, burning with urination, pelvic pain, bleeding between periods, rectal pain or discharge, or testicular discomfort, but none of these are required for infection to be present. Untreated chlamydia can move beyond the site where it was acquired. In people with a uterus and fallopian tubes, ascending infection can cause pelvic inflammatory disease, which can lead to chronic pelvic pain, infertility, or increased risk of ectopic pregnancy. In people with testes, infection can involve the epididymis and cause pain or swelling. Rectal infection can cause proctitis. The fact that the infection is curable does not mean that every consequence of a delayed diagnosis is automatically reversible. Testing is usually performed with the nucleic acid amplification test. The correct specimen depends on the exposure. Urine can be useful for urethral infection. Vaginal swabs are highly effective for vaginal and cervical screening. Rectal exposure may require a rectal swab. The central lesson is the same. A negative urine test cannot be assumed to clear every other body site. After treatment, reinfection is common enough that CDC recommendations call for retesting at roughly 3 months in many people treated for chlamydia, even if they believe their partners were treated. This is not because the antibiotic usually did not work. It is because sexual networks reconnect. A treated person can be cured and then exposed again by a partner who was never treated, did not complete treatment, or acquired infection from someone else. Think about this. Have you ever been treated for chlamydia, but never had partner management or a repeat test about 3 months later? If yes, the practical implication is that the old episode may still matter to your current screening plan, especially if you resumed sex with an untreated or uncertain partner. Gonorrhea is caused by Neisseria gonorrhoeae. It can infect the urethra, cervix, or vagina, rectum, throat, and more rarely, the eyes or other parts of the body. Like chlamydia, it can be asymptomatic. Throat gonorrhea is particularly easy to miss because a person may feel completely normal. That matters because the throat is not merely a passive location. It is also a biologic environment where gonorrhea can exchange genetic material with related bacteria. One reason antimicrobial resistance is such an important public health concern. Gonorrhea has repeatedly evolved resistance to antibiotics that once worked well. Treatment recommendations have changed over time because the organism changes. That is why using leftover antibiotics, copying an old regimen from the internet, or assuming the treatment a friend received years ago is still the right treatment is poor practice. Modern gonorrhea management uses current clinical guidance, and the recommended treatment can differ depending on allergy, pregnancy, weight, and site of infection. Pharyngeal, or throat, gonorrhea deserves special attention. It can be harder to eradicate than uncomplicated infection at some other sites, and current guidance recommends a test of cure after treatment for pharyngeal gonorrhea. A person who only had a urine test after oral exposure may never have tested the throat at all. This is one of the clearest examples of why full panel is not a scientifically precise phrase unless the person knows what specimens were collected. As with chlamydia, retesting about 3 months after treatment is commonly recommended because reinfection is frequent. Partner evaluation and treatment matter. In Georgia, expedited partner therapy may be available in certain circumstances through public health systems, which can help get treatment to partners who might otherwise not present for care. Think about this. During your last STI screen, were any throat or rectal swabs collected when those sites had been exposed? If the answer is no, the practical implication is that your previous testing may have been incomplete for those exposures, even if every result you received was negative. Syphilis is caused by the bacterium Treponema pallidum. Its reputation as a great imitator comes from the fact that its manifestations can resemble many other conditions. Early syphilis may begin with a chancre, often a painless sore at the site of infection. Because the sore can be painless and can occur inside the rectum, vagina, mouth, or another location that is not easily seen, a person may never notice it. Secondary syphilis can produce a widespread rash, classically including the palms or soles, but the rash can vary. Other symptoms can include fever, swollen lymph nodes, sore throat, patchy hair loss, headache, fatigue, or mucous membrane lesions. Then syphilis can become latent. The visible symptoms disappear, but the infection has not necessarily disappeared. Without treatment, some people later develop serious complications involving the nervous system, cardiovascular system, eyes, or ears. Neurosyphilis, ocular syphilis, and otosyphilis can occur outside the simplistic idea that neurologic disease only appears decades later. New visual symptoms, hearing changes, cranial nerve symptoms, or neurologic problems in a person with possible syphilis exposure deserve medical attention. Syphilis testing usually combines 2 kinds of blood tests: a treponemal test that detects antibodies directed at the organism, and a non-treponemal test, such as an RPR, that helps assess disease activity in response to treatment. Testing algorithms can begin with either category depending on the laboratory. The result is interpreted in context, because a treponemal test can remain positive long after successful treatment in many people, while non-treponemal titers can change over time. Pregnancy makes syphilis especially urgent because untreated maternal infection can cause miscarriage, stillbirth, neonatal death, or congenital syphilis. Screening is therefore a routine part of prenatal care, with repeat testing recommended in people at increased risk or in high-burden settings. Think about this. Have you had a new unexplained painless sore, a generalized rash that involved the palms or soles, unexplained patchy hair loss, or a partner diagnosed with syphilis? If yes, the next move is to seek syphilis testing and clinical evaluation rather than waiting for the symptom to resolve. Syphilis symptoms can disappear even when the infection remains. Hepatitis C is a viral infection that primarily targets the liver. It belongs in a comprehensive sexual health assessment, but it should not be explained as though its transmission pattern is identical to gonorrhea or chlamydia. Hepatitis C is transmitted efficiently through blood. Sharing injection equipment is a major route. Sexual transmission can occur, and risk is higher in some sexual contexts, particularly when blood exposure, traumatic sex, certain networks, or HIV are involved, but the biology is fundamentally bloodborne. The striking thing about hepatitis C is the gap between how serious chronic infection can become and how quiet it can be at first. Many people with chronic infection have no symptoms for years, while liver injury accumulates. Chronic hepatitis C can eventually cause cirrhosis, liver failure, or liver cancer. At the same time, modern direct-acting antiviral treatment can cure the large majority of infections. The disease is therefore a powerful example of why screening matters. It is often silent, it can cause major long-term harm, and it is now highly treatable. CDC guidance recommends that all adults 18 and older be screened for hepatitis C at least once in their lifetime, with limited exceptions for extremely low prevalence settings, and that all pregnant patients be screened during each pregnancy. People with ongoing risk, such as current injection drug use with shared equipment, need periodic testing rather than a one-time lifetime test. Anyone who requests hepatitis C testing should be able to receive it without having to disclose a stigmatized risk history. There is no vaccine for hepatitis C. Prevention is therefore based on avoiding blood exposure, using sterile injection equipment, appropriate infection control practices, and addressing sexual practices that involve blood exposure when relevant. A positive hepatitis C antibody test shows that exposure occurred at some point, but a separate viral RNA test is used to determine whether current infection is present. A person can have a positive antibody test after clearing or curing infection and not have active virus. Hepatitis B is different from hepatitis C in two important ways. First, hepatitis B can be transmitted sexually, as well as through blood and from parent to infant around birth. Second, there is an effective vaccine. For adults, modern public health policy has moved away from trying to identify only the people who will admit to a specific risk factor. CDC now recommends that all adults 18 and older be screened for hepatitis B at least once in their lifetime, using a 3-part or triple panel blood test when they have not previously been screened. The triple panel includes hepatitis B surface antigen, antibody to hepatitis B surface antigen, and total antibody to hepatitis B core antigen. Together, those markers can help distinguish current infection, previous resolved infection, immunity from vaccination, and susceptibility. This is more informative than a single test, because the question is not only, do you have hepatitis B right now? It is also, are you immune? Were you infected in the past? Or are you still vulnerable? Vaccination recommendations are broad. Routine hepatitis B vaccination is recommended for adults 19 through 59 years old. Adults 60 and older with risk factors should receive vaccination, and adults 60 and older without known risk factors may also receive it. A person who requests hepatitis B vaccination should not be treated as though they need to prove they deserve it. Vaccination is one of the most straightforward ways to remove an infection from a person's future risk landscape. Think about this. Do you know, not guess, whether you completed a hepatitis B vaccine series and whether you have ever had hepatitis B screening? If the answer is no, the next move is to add hepatitis B vaccination and screening history to your next primary care or sexual health visit. I probably got it as a child, may be correct, but it is not the same as knowing your immunization status. A pregnancy test detects human chorionic gonadotropin, usually abbreviated HCG, a hormone produced after implantation. The timing of testing matters because HCG does not become detectable the moment sex occurs or the moment fertilization occurs. A person can test too early and receive a negative result while still being pregnant. The FDA notes that for the most reliable home results, testing 1 to 2 weeks after a missed period gives greater certainty than testing extremely early. First morning urine can improve sensitivity because it is more concentrated. Even on the first day of a missed period, some pregnancies will not yet be detected by a home urine test. If a pregnancy test is negative, but the period still does not come, repeating the test after several days or obtaining clinical testing is reasonable. Now, separate pregnancy risk from STI risk. Condoms can reduce both pregnancy and infection risk, but many contraceptive methods only address pregnancy. An intrauterine device, implant, pill, patch, ring, or injection can be highly effective contraception and still provide no protection against HIV, gonorrhea, chlamydia, or syphilis. Conversely, PrEP can provide powerful HIV prevention and does not prevent pregnancy. The prevention plan has to match the outcome a person wants to prevent. If unprotected sex or contraceptive failure occurred recently and pregnancy is not desired, emergency contraception may still matter. The copper intrauterine device is the most effective emergency contraception and can be placed within 5 days of unprotected sex. Ulipristal acetate can be used up to 5 days after unprotected sex and maintains effectiveness better across that period than levonorgestrel. Levonorgestrel emergency contraception works best as soon as possible and is commonly available over the counter. Emergency contraception does not treat or prevent sexually transmitted infections, so a person may need both pregnancy prevention and STI or HIV evaluation after the same event. Think about this. Was there penis and vagina sex during a time when pregnancy was possible and contraception was absent, failed, or was used inconsistently? If yes, and the event was within 5 days, the next move is to consider emergency contraception now rather than waiting for a pregnancy test. If more time has passed, plan pregnancy testing based on the menstrual timeline and seek care for pain, heavy bleeding, or other concerning symptoms. When people request every STI test, they often imagine one blood draw and one urine sample. That is not how sexual health diagnostics are organized. Herpes and human papillomavirus show why. Herpes simplex virus can be transmitted through skin-to-skin contact, including when a person does not have a visible sore. Herpes type 1 is common and may be oral or genital. Herpes type 2 more often causes genital infection, although location and type do not map perfectly. When a fresh lesion is present, a swab from the lesion can be the most useful diagnostic test. Blood antibody testing can sometimes help in selected situations, but routine herpes screening of every asymptomatic person is not recommended as a universal population strategy because of limitations in interpretation, false positive concerns at low index values with some assays, and the fact that a positive antibody test does not always identify the exact site of infection. Human papillomavirus, or HPV, is also common and spreads through intimate skin-to-skin sexual contact. Some HPV types cause genital warts. Other high-risk types can contribute to cervical, anal, penile, vulvar, vaginal, and oropharyngeal cancers. There is no routine blood test that tells an adult, you have no HPV anywhere. Prevention, therefore, relies heavily on vaccination and on recommended cancer screening, such as cervical screening based on age and current guidelines. HPV vaccination is one of the major cancer prevention tools inside sexual health care. These infections also show why condoms, while extremely valuable, do not reduce every sexually transmitted infection to zero. A condom covers a specific area. Skin-to-skin infections can involve areas not covered by the condom. That does not mean condoms are ineffective. It means sexual health prevention is layered. Vaccination, barriers, testing, treatment, PrEP where appropriate, and partner communication each solve different parts of the problem. Trichomoniasis is caused by the parasite Trichomonas vaginalis. It can cause vaginal discharge, irritation, odor, pain with urination, or discomfort during sex, but many infections are asymptomatic. Testing practices vary by population and setting. It is particularly relevant in people with vaginal symptoms, people living with HIV, and some higher prevalence clinical settings. There are also conditions that produce genital symptoms, but are not classified as classic sexually transmitted infections. Bacterial vaginosis is associated with shifts in vaginal bacteria and sexual activity patterns, but is not simply an infection acquired from one partner in the way gonorrhea is. Yeast infection can cause itching and discharge, but is not usually sexually transmitted. Urinary tract infections can cause burning with urination and can be confused with urethral STI symptoms. Irritation from products, friction, dermatologic conditions, or allergic reactions can also mimic infection. The practical lesson is that symptoms should not automatically be self-diagnosed as one specific STI. Burning does not equal chlamydia. Discharge does not automatically equal gonorrhea. A sore does not automatically equal herpes. A rash does not automatically equal syphilis. The clinical task is to combine exposure history, anatomy, examination when needed, and the right laboratory tests. Now turn the information back onto your own history, but do it the way a clinician would do it rather than the way anxiety does it. Start with your last sexual health screen. Do you know what was actually tested, or do you only remember being told that everything was negative? Those are not the same thing. If you can get the report, look at the names of the tests and the specimens. A blood test may have covered HIV and syphilis. A urine sample may have covered urethral chlamydia and gonorrhea. If oral sex or receptive anal sex occurred, ask whether the throat or rectum was tested. If you do not know, do not treat the phrase full panel as proof that every relevant infection in every exposed body site was assessed. Next, look at what happened after that test. A negative result from 6 months ago does not describe exposures that happened last month. New partners, multiple partners, an anonymous partner, a partner with a newly diagnosed STI, a condom break, or sex after the last test all change what that old result can tell you. Then look at the anatomy of the exposure. Was there oral sex, vaginal or frontal sex, receptive anal sex, insertive anal sex, shared injection equipment, blood contact, penis and vagina sex, where pregnancy was possible? Do not answer with an identity label. Answer with what actually happened, because laboratory testing follows anatomy, not identity. If a penis was in your throat, a throat swab for gonorrhea may matter. If there was receptive anal sex, rectal testing for chlamydia and gonorrhea may matter. If pregnancy could result, and the event happened within 5 days, emergency contraception may still matter before a pregnancy test can tell you anything useful. Then ask whether any HIV prevention was already operating. Were you taking PrEP consistently? Was the partner living with HIV and durably undetectable? Was a condom used correctly from start to finish? Did the exposure occur within the 72-hour PEP window? Those facts can radically change the HIV part of the assessment. If you are within 72 hours and PP might be indicated, that becomes the priority. If exposures of this kind happen repeatedly, the better long-term answer may be PrEP, rather than repeatedly waiting until after sex to reconstruct the risk. Now look at symptoms, but do not let symptoms become your entire diagnostic system. Burning with urination, new discharge, pelvic pain, testicular pain, genital sores, rash, rectal pain, bleeding, fever, or unexplained symptoms deserve evaluation, but the absence of those symptoms does not clear you. Chlamydia, gonorrhea, syphilis, HIV, hepatitis C, and other infections can all be present without an obvious warning sign. Then look at vaccination. Do you know whether you completed hepatitis B vaccination? Do you know whether you completed HPV vaccination if you were eligible? Vaccination is not a vague wellness extra here. It permanently changes the set of infections you have to worry about. Next, look at your treatment history. Have you ever had chlamydia, gonorrhea, or syphilis, and then resumed sex before partners were treated? Were you retested at the recommended interval? Repeated bacterial STIs are often reinfections, not mysterious treatment failures. If you are a gay, bisexual, or other man who has sex with men, or a transgender woman, and you had syphilis, chlamydia, or gonorrhea in the last 12 months, that history is also a reason to ask a clinician whether Doxy PEP belongs in your prevention plan. Then look at the circumstances around sex. If alcohol or drugs repeatedly make it harder to remember what happened, use condoms, negotiate boundaries, or know whether consent was present, that is not a character judgment. It is clinically relevant information because a prevention strategy that only works when you are completely sober is not a complete strategy if sex does not always happen under those conditions. Finally, look at what you rely on from partners. The word clean is not a laboratory value. The statement "I am negative" is incomplete unless you know what was tested, when it was tested, and whether there were exposures afterward. A partner living with HIV who is durably undetectable is not a transmission threat through sex. A partner who tested negative before their most recent exposure may not actually know their current status. The purpose of this self-assessment is not to calculate a moral score, it is to identify the next concrete action. That action might be PEP now, emergency contraception now, a site-specific STI screen, a properly timed HIV test, pregnancy testing later, vaccination, partner treatment, PrEP, Doxy, PEP for an eligible person, or simply continuing routine screening because nothing in the history changes the plan. Doxy PEP means taking doxycycline after sex to reduce the chance of certain bacterial sexually transmitted infections. It is not a universal recommendation for every sexually active adult. Current CDC guidance recommends that clinicians discuss Doxy PEP with gay, bisexual, and other men who have sex with men, and transgender women who had syphilis, chlamydia, or gonorrhea diagnosed in the previous 12 months. When prescribed, the recommended approach is 200 milligrams of doxycycline as soon as possible after oral, vaginal, or anal sex, no later than 72 hours afterward, and not more than 200 milligrams in a 24-hour period. Clinical trials in the populations for whom it is recommended showed large reductions in syphilis and chlamydia and a more modest, variable reduction in gonorrhea. The reason the recommendation is selective is not because other people are undeserving of prevention. It is because the evidence base is stronger in some populations than others, and widespread antibiotic exposure raises legitimate questions about antimicrobial resistance and changes to the microbiome. A clinician should evaluate whether the expected benefit outweighs those concerns for the individual person. Doxy PEP also does not replace screening. People using it still need testing at the body sites that were exposed, generally on a regular schedule determined with the clinician. It does not prevent HIV, hepatitis C, herpes, HPV, or pregnancy. It should be thought of as another layer inside a comprehensive strategy, not a pill that makes sexual health follow-up unnecessary. Sexually transmitted infections are often discussed as though they are individual medical events. In reality, they move through networks. A person can take every dose correctly, test negative afterward, and still be reinfected if a partner remains untreated. This is why clinicians ask about partners and why health departments have partner services. It is not surveillance for its own sake. It is part of breaking a transmission chain. This also explains why repeated infections do not necessarily mean that treatment failed. Reinfection is common. When someone is treated for chlamydia or gonorrhea, retesting around 3 months is recommended in many situations because the probability of a new exposure is clinically meaningful. Syphilis follow-up is based on stage, treatment, symptoms, and changes in the non-treponemal antibody titer. If a partner tells you that they were treated, the useful questions are whether they completed the treatment, whether they were instructed to avoid sex for a period afterward, whether all relevant partners were treated, and whether they resumed sex before those conditions were met. In some situations, clinicians or public health programs can use expedited partner therapy, where medication or a prescription is provided for a partner without the partner first completing a traditional clinical visit. The rules depend on the infection and jurisdiction. If you are in Atlanta, it helps to understand that the local sexual health system is not one clinic doing everything. Different organizations occupy different parts of the system. Fulton County Public Health provides sexual health and HIV services, including STI testing and treatment, HIV testing, pregnancy testing, linkage to PrEP, and other public health services. Fulton County also operates HIV prevention and care programs through its broader HIV services system. Positive impact. Health centers is another major part of the Metro Atlanta infrastructure. Its patient-facing centers in Decatur, Duluth, Marietta, and Clayton County provide HIV testing, STI screening, PrEP, PEP, HIV medical care, pharmacy, and supportive services. That can be especially useful for someone who wants prevention and ongoing care in the same system instead of treating every test as an isolated event. Grady's Ponce de Leon Center occupies a different role. It is one of the major HIV treatment centers in the region and has decades of experience with comprehensive HIV and infectious disease care. For a person who has been diagnosed with HIV and needs specialized care, Ponce is part of the city's core clinical infrastructure, with medical care, laboratory services, pharmacy, case management, mental health support, and other services built around long-term treatment. Planned Parenthood's East Atlanta Health Center is useful when infection prevention and reproductive health overlap. It offers STI testing and treatment, HIV services, pregnancy testing and planning, contraception, emergency contraception, vaccines, and other sexual and reproductive health services. The hidden practical point is that where you go should depend on what problem you are trying to solve. If you are inside a 72-hour PEP window, the priority is not finding the prettiest clinic or the cheapest routine screening package. The priority is reaching a place that can evaluate and prescribe PEP fast enough for the medication to matter. If you need routine STI screening, a county sexual health clinic or community organization may be the simplest route. If you have a new HIV diagnosis, linkage into dedicated HIV care matters more than continuing to shop around for another screening test. If pregnancy prevention is part of the same exposure, a reproductive health clinic can sometimes address contraception, emergency contraception, pregnancy testing, and STI care in one place. Atlanta actually has a substantial sexual health infrastructure. The harder problem is that many people do not know how the pieces fit together until they are already in a crisis. There is also a historical reason modern sexual health care looks so different from the way many adults were taught about it in school. HIV emerged as a recognized epidemic in the early 1980s, and for years, prevention was forced to operate in a world with no effective long-term treatment and no medication a person without HIV could take before sex to prevent infection. The first antiretroviral drugs changed that picture only partially. Combination antiretroviral therapy in the 1990s transformed HIV from an infection that often progressed rapidly to AIDS into a manageable chronic condition for people who can access and remain on effective treatment. The Ryan White Care Act, enacted in 1990, built a federal safety net structure around HIV care. That policy matters because HIV treatment is not just a pharmacology problem. A prescription does not work if a person cannot get to the clinic, cannot afford medication, loses insurance, has unstable housing, or cannot stay connected to care. Modern HIV systems therefore combine medicine with case management, insurance navigation, transportation, behavioral health, and other support. Then PrEP arrived in 2012 and changed the prevention logic again. For the first time, an HIV-negative person could take medication before exposure and control a major part of their own HIV prevention without needing to know or control every partner's behavior. Long-acting injectable PrEP reduced dependence on a daily pill. In 2025, injectable lenacapavir expanded the menu further with a twice-yearly option for people who would benefit from PrEP and meet prescribing criteria. At the same time, the evidence behind U equals U established one of the most consequential facts in modern HIV medicine. A person living with HIV who maintains viral suppression does not sexually transmit HIV. That is both a medical fact and a correction to decades of stigma. Doxy PEP added another layer for selected people at elevated risk of bacterial STIs. HPV and hepatitis B vaccination added prevention before infection. Emergency contraception created a time-sensitive way to reduce pregnancy risk after sex. Site-specific NAAT testing made it possible to find infections in the throat and rectum that an old-fashioned urine-only mindset could miss. What has happened over the last several decades is a shift from a prevention model dominated by fear, abstinence messages, condoms, symptom recognition, and treatment after diagnosis into a layered biomedical system. Condoms still matter. They are simply no longer the only tool. The modern system includes vaccination, HIV treatment as prevention, PrEP, PP, long-acting medications, Doxy PEP for selected populations, site-specific screening, rapid treatment, partner services, emergency contraception, and a public health safety net. The biggest gap in 2026 is often not that the tools do not exist. It is that people were never taught the architecture well enough to use them. A strong sexual health plan is not the plan that sounds most disciplined in theory. It is the plan that survives your actual life. If condoms are used every time and correctly, keep them available in the places where sex actually occurs, rather than assuming they will appear when needed. If you repeatedly have HIV anxiety after sex, consider PrEP, instead of repeatedly reconstructing risk after exposure. If you use long-acting PrEP, put the injection schedule somewhere that cannot be casually forgotten. If you take daily oral PrEP, connect it to a routine that already happens every day. If oral or anal exposures occur, make sure your testing site knows, because specimen collection should follow exposure sites. If you have been treated for chlamydia or gonorrhea, plan the recommended retest rather than assuming treatment closes the story forever. If you have not completed HPV or hepatitis B vaccination, and you are eligible, vaccination can permanently simplify parts of your risk profile. If pregnancy is not desired, have a contraception plan and know where emergency contraception can be obtained before it becomes an emergency. If a partner is living with HIV, learn whether they are durably virally suppressed rather than treating the diagnosis itself as the risk variable. If a partner says they are negative, ask when and how they tested and whether they had exposures afterward. If there is a possible HIV exposure and you are within 72 hours, seek PEP rather than waiting for symptoms. If you are outside the window, get the right HIV test at the right time, and do not let one test taken too early create false certainty. Finally, build a relationship with at least one place where you can receive sexual health care without starting from zero every time. In Atlanta, that might be a county health department, positive impact health centers, AID Atlanta, Planned Parenthood, a primary care clinician comfortable with sexual health, or another qualified clinic. The point is continuity. Sexual health is easier to manage when someone knows your testing history, vaccination status, PrEP or PEP history, medication list, and the kinds of exposures that actually occur. The easiest way to know whether you understood this lecture is to see whether your questions have become more precise. Instead of asking, do I have an STI, you should be able to ask which infections are plausible from this exposure, at which body sites, and which tests actually cover those sites. Instead of asking, was my HIV test negative, you should be asking what kind of HIV test it was, how long after exposure it was performed, and whether PrEP, PEP, or another antiretroviral medication could change the interpretation. Instead of hearing that a partner has HIV and automatically assuming transmission risk, you should be asking whether that partner is durably undetectable. Instead of waiting for symptoms after a possible HIV exposure, you should know that PEP is a 72-hour intervention, and sooner is better. Instead of treating PrEP as one pill for one stereotype of person, you should know that HIV prevention now includes daily oral options, injections every 2 months, and a twice-yearly injectable option, and that current CDC guidance says clinicians should inform sexually active adolescents and adults about PrEP and prescribe it to people who ask for it when clinically appropriate. Instead of believing a urine test means every STI at every body site was checked, you should understand why throat and rectal swabs can matter. Instead of assuming a negative pregnancy test the morning after sex rules out pregnancy, you should understand that biology needs time before a test can detect what happened. Instead of treating chlamydia, gonorrhea, or syphilis as a one-person event, you should understand reinfection and partner treatment. And instead of imagining that sexual health is one giant risk score, you should be able to identify the next action that changes the outcome. If you are inside the PEP window, act now. If emergency contraception is still an option and pregnancy is not desired, act while the option is still useful. If testing is needed, match the test to the exposure and the timing. If you have ongoing HIV exposure potential, talk about PrEP before the next exposure. If you have never had hepatitis B or hepatitis C screening, bring it into routine care. If you do not know your hepatitis B or HPV vaccination status, find out. If a previous screen did not match the body sites that were exposed, fix that on the next screen. Good sexual health is not the absence of sex, and it is not the absence of uncertainty. It is the ability to understand the biology well enough that uncertainty does not control the decision. You know what happened. You know what the clock means. You know what prevention tools exist. You know what a test can and cannot tell you. And you know when the next move is not more searching, more guessing, or more fear, but simply getting the right care at the right time.